Hi, my name is Mary Kim, and I am a postbac student at GGC. Today, I will be having the pleasure of presenting to you my critical review of the article Supplementation with Vitamin D or Omega-3 Fatty Acids in Adolescent Girls and Young Women with Endometriosis. Endometriosis is a gynecologic disorder characterized by the presence of endometrial tissue outside of the uterus, leading to a chronic inflammation and pain. The most notable type of pain caused by endometriosis is pelvic pain. Endometriosis is especially prevalent among adolescents and young women, thus explaining why the authors decided to choose the population that they did. This is a serious condition that significantly impacts one's quality of life, school attendance, and social relationships. Even with there being a substantial amount of women who deal with this condition, there is yet to be a treatment or even an understanding of what causes this condition. Because of the high prevalence and substantial delay in diagnosis, which averages 7 years, the authors highlighted the importance of this study. Given the chronic nature of the disease and the limitations of current treatments, exploring alternative management strategies such as nutritional supplementation is crucial. This particular study aimed to evaluate the effects of vitamin D and omega-3 fatty acid supplementation on pain management in adolescent girls and young women with endometriosis. The study focuses on vitamin D and omega-3 fatty acids due to their known anti-inflammatory properties. Vitamin D has been shown to reduce the proliferation of inflammatory factors and increase cell apoptosis, while the omega-3 fatty acids have been shown to decrease growth factors and limit cell survival. This is important because all these characteristics could potentially be used to reduce the progression of endometriosis or decrease inflammation to subdue pelvic pain. The only limitation was that there was a notable gap in clinical evidence supporting that these claims could be supplemented for pain management of endometriosis. The study aimed to close the gap between the theoretical benefits and clinical data by conducting research. Through this study, the authors aimed to provide empirical data on the effectiveness of vitamin D and omega-3 fatty acids in alleviating endometriosis-related pain, improving quality of life, and reducing the frequency of pain medication use. This study was a single-site, double-blind, randomized, placebo-controlled, multi-arm parallel study performed in the United States. This means that the study was conducted at only one location, with multiple groups that received different treatments. These groups were studied simultaneously, and participants were randomly assigned to these groups to avoid bias. To further avoid bias, neither the participants nor the researchers knew who received the active treatment or the placebo. The study made use of a case definition, which is a list of the inclusion and exclusion criteria that must be met in order for an individual to be classified as a person eligible as a participant in the study. The case definition for this study includes non-pregnant females aged 12 to 25 with surgically confirmed endometriosis from the Pediatric Gynecology Clinic at Boston Children's Hospital. They were also required to have a visual analog scale, or VAS score, of at least 3 out of 10 for pain due to the illness. Those that were excluded were patients with a history of kidney stones or concurrent illnesses known to affect gastrointestinal absorption of nutrients, and those with a baseline 25-hydroxy-vitamin D concentration of greater than 100 nanograms per milliliter. Those with a history of kidney stones were excluded because high vitamin D levels could increase calcium absorption and increase the risk of developing even more kidney stones. Also, those with illnesses affecting gastrointestinal absorption were excluded because these conditions can impair the body's ability to absorb the vitamin D and omega-3 fatty acids, leading to inconsistent or unreliable results due to the varying absorption levels among participants. Similarly, those with the vitamin D concentration greater than 100 nanograms per milliliter were excluded because a concentration in this range is considered excessive, and if more is consumed could lead to problems like hypercalcemia. The case definition was constructed to include individuals that would not be harmed while obtaining data without bias and inconsistency to the best of their abilities. Once they found participants that fit these criteria, 69 participants were randomly assigned and given a bottle containing their study medication. 22 participants were allocated to the placebo, 27 were allocated to vitamin D, and 20 participants were allocated to ω-3 fatty acid. They also completed a baseline survey containing demographic information, pain, medication history, etc. that was just an expanded version of the World Endometriosis Research Foundation's standard clinical questionnaire, along with a standardized 128-question FFQ to obtain information about their usual food and nutrition intake during the past year. All participants also had laboratory testing done at the baseline and 6-month visit to obtain ω-3 and vitamin D measurements as a means of testing compliance with taking the nutrient assigned. However, primary outcome measure was pain, which was assessed using the VAS, and the secondary outcome measures of quality of life, pain, catastrophizing, and pain medication usage were those measured by the short form 12 questionnaire, which were given at every visit, baseline, 3 months, and 6 months. When measuring statistical analyses, an intention to threat analysis was employed, meaning that all participants were analyzed in the groups to which they were originally assigned, regardless of whether or not they completed the study or followed study protocol. This was employed under the assumption of missing at random, meaning that any differences between the missing and observed data can be explained by the observed data, allowing the use of statistical methods without introducing significant bias. In doing so, linear mixed models were used to compare change in pain severity, physical and mental quality of life, catastrophic thinking, and mean number of non-narcotic pain pills taken per week over the course of the study period. A significant change in VAS pain scores was determined as a score change that was greater than or equal to 1.6. All statistical analyses were performed using SAS. The study found improvements in pain across all groups, including the placebo, but no significant differences between the supplement and placebo groups. Although the vitamin D group showed some reduction in pain, the change was not significantly greater than that in the placebo group. Similarly, fish oil supplementation resulted in modest improvements but did not outperform the placebo. These findings underscore the possibility of a placebo effect and the importance of including a control group in pain-related studies. Additionally, no substantial differences were observed in secondary outcomes, such as quality of life and medication usage, highlighting limitations in the supplement's effectiveness. Specifically, the mean visual analog scale pain scores for the worst pain in the past month decreased from 7 to a 5.5 in the vitamin D group, from a 6 to a 4.4 in the placebo group, and from a 5.9 to a 5.2 in the fish oil group. While the vitamin D group saw a statistically significant reduction in pain, with the p-score value being that of 0.02, this improvement was not significantly different from the placebo group, whose p-score was 0.07. Similarly, the fish oil group did not show a statistically significant change, with their p-score being that of 0.39. These results suggest that the reductions in pain across all groups may be largely attributable to the placebo effect rather than the supplements themselves. Regarding secondary outcomes, there was no significant differences in quality of life measures or the number of non-narcotic pain medications taken weekly between the groups. The SF-12 physical and mental component scores remained largely stable across all participants, with no notable changes in catastrophic thinking scores except for a modest improvement in the vitamin D group. These findings indicate that although the supplements may have some impact on pain perception, they do not significantly alter overall quality of life or pain management behaviors. Nutrient supplementation of vitamin D and ω-3 fatty acid did not lead to significant improvements in endometriosis-related pain when compared to a placebo, indicating that their perceived benefits may stem from placebo effect rather than the supplements themselves. One of the major strengths of this study is its well-thought methodological design. It is a double-blind, placebo-controlled, which minimized bias, allowing for a more accurate assessment of the supplement's effectiveness. They use VAS and short form 12 to assess levels of pain and quality of life, which are validated techniques in clinical research. The use of these validated measures further adds credibility to the findings. Also, the inclusion of biochemical assessments of ω-3 fatty acids and vitamin D to confirm compliance with the supplement regimen is a notable strength, ensuring that the observed effects can be attributed to the interventions. Furthermore, the study also emphasized the role of the placebo effect in clinical trials focused on pain management. The similar levels of improvement in the placebo group suggest that factors like increased clinical attention and the psychological impact of participating in a trial may significantly influence perceived pain relief. This highlights the importance of rigorous control conditions in future studies to accurately determine the efficacy of interventions. However, the study's small sample size is a significant limitation. With only 69 participants, the study may not have been able to detect small but clinically meaningful differences between the groups. A larger sample size would provide more detailed, precise data, which would allow a better analysis of effects between groups. Also, the failure to verify the purity of the supplements that were taken raises concerns about the consistency and quality of the interventions, which could have influenced the results. Another area for improvement is the study's focus on a relatively short intervention period of only 6 months. Endometriosis is a chronic condition, and longer-term studies are needed to fully understand the potential benefits and limitations of nutritional supplementation. Future research should also explore the effects of different dosages and combinations of supplements to determine the most effective strategies for managing endometriosis-related pain. Overall, while the study provides valuable insights into the potential role of vitamin D and ω-3 fatty acids in managing endometriosis pain, it also highlights the need for further research. Larger, longer-term studies with verified supplement quality are essential to build on these findings and develop evidence-based recommendations for nutritional interventions in endometriosis management. And that concludes my critical review. Thank you all so much for listening to my presentation.